So you are gonna have your first day in the ICU, and you wanna know, what should I know? What should I grasp onto? And honestly, that is a very hard question. Even thinking on it now, I was fortunate enough because I really wanted to go to the ICU beforehand, and I wanted to pursue anesthesia school. So realistically, I was studying a lot. I was figuring out things before I even got there. But that is not an expectation. It's a job. You need to expect from yourself that you're going to be a nurse who has just taken the NCLEX and has gone through nursing school. That is all you should expect out of yourself. Because when you go to the ICU, it's expected that you don't know anything. They're starting you out from zero. Just because you might know about the ventilator doesn't mean that you're going to start at 10. Just because you know about drips and how medications work doesn't mean you're going to start at 50. We're all starting at zero. It's all about learning. So really take in all those experiences. And it is okay that you don't know things. How you go from not knowing something to knowing something is just by asking questions. Let's talk about medications. So in a general ICU, there's a lot of medications. In a specialty ICU, there's a lot more medications. So how do you know them all? Time. It's that simple. Once you learn about how you use a medication, for example, let's talk about Levophed or norepinephrine, which is used to increase blood pressure. So I know that, okay, I'm going to give this dose based on my hospital's protocols. And usually you can see that in what's called a MAR, or a medication administration record. And they'll tell you your reference doses and how high and how low you can go and how much you can titrate that medication by to achieve a certain goal. Now, how do you just remember that? Once again, time. You can't sit there and just memorize it before you show up on the job. One, it's going to be really, really excruciating, and it's going to be difficult and overwhelming for you for your first day. Once you move from one medication, maybe you learn another one that's similar. Then you learn something else that's similar too. Now you have a group of medications that you understand that are similar, but just maybe work a little bit differently, or their parameters are a little bit different from one another. Now when you get into specialty areas, you will start having bread and butter medication. Like, I'm always going to use this one. I'm always going to use this one for this thing. And typically physicians are going to have certain medications that they like to use versus other medications. One physician might like to use propofol and fentanyl for sedation. Another one might just like to use Versed and propofol. So realistically, and those are just sedation medications, and it just depends on what they want and what the goal they're trying to achieve. So just become familiar with, these are the 10 medications we're going to use all the time, and go home and just look up just small facts. Then after a while, the small facts become your knowledge. Then you'll go and you'll become even more equipped to learn and understand them more and more, and even learn how their adverse effects are happening and why they're happening. For example, with propofol, it's that white medication, and we give that to sedate a patient, so to calm them down. But if you give too much propofol over a long period of time, you can actually cause an increase in triglycerides. And then you could cause propofol infusion syndrome. And that is not a typical event to happen, but it's important that I understand and know that is a possibility to treat or to stop the medication if I were to see those signs. So that's how you build up your knowledge in medications within the ICU. So let's talk about two scary situations in the ICU. One being intubation and one being cardiac arrest. With intubation, that's terrifying because you're going to be artificially breathing for that patient. The ventilator's intimidating, the tube coming out of their mouth is intimidating, and what happens during that time when you're doing that is also very intimidating. As a new grad nurse, it's a brand new experience. So sometimes it's better for you to sit back and just watch everybody work. Usually what's going to happen is going to be a respiratory therapist there who is there to help the advanced provider to intubate the patient. So whether it be handing the endotracheal tube, getting the ventilator set up, suctioning the airway, which is because this patient at this time probably can't breathe or is breathing ineffectively. So it's very common for people to get aspiration pneumonia because they're not able to protect their airway. So the advanced provider, whether it be a NP, physician assistant, or even a CRNA, can intubate the patient. And what's going to happen is they're going to get a blade, and they're going to open up the airway, and they're going to take an ETT tube, and they're going to place it into the airway. Once that happens, it's very important that that patient is going to get bagged or put on the ventilator. Bagging is when you take a ambu bag, place it on top, and you push in air into the lungs. And you will see the lungs expand and deflate as you push and as you release. What's also very important for you as the nurse or the person giving the medication is that you need to know what to give and how much. So this goes back into knowing your medications. So for sedation, are we going to use etomidate, or are we going to use propofol, or we use fentanyl, or there's a lot of different medications and why we use them in those situations. So it's very important that you have a grasp on maybe 5 or 6 medications that you typically use in an intubation situation and know the dosages. For example, I know that etomidate is 2-to-1. So if somebody were to throw out a number to me, I can do the math real quickly. For SED is 1-to-1, which is pretty easy there, and so on and so forth. Now, your patient's intubated, right? Everything seems to be going okay. Now you start noticing that their oxygen numbers, or the oxygen saturation, is going from 95 to 90 to 80, and now you start seeing their heart rate decrease also. Now, during that time, you're frantic. You don't know what to do, but you do know that something bad is about to happen. This is the next situation that's going to come, and that's called cardiac arrest. So at this point, this patient isn't getting oxygen to where they need it to go. The question is why? Is it because their heart's not pumping well, or is it because their body's not getting oxygen pulled out the way that they need it to? Either way, your patient has gone to cardiac arrest now. What should you do? One thing I want to tell everybody is that whether you're on the floor in the ICU, cardiac arrest is a control situation. We have multiple protocols on how you should manage a patient in cardiac arrest. I'm not going to talk about how to manage whether it be pulseless electrical activity versus a VTAC, but you should take the time to understand and know that. Maybe later we'll have a conversation about that stuff. But when your patient goes to cardiac arrest, and let's say there's no pulse and there's no electrical activity, just a flat line, you will what's called get on the chest, and you'll start doing compressions. And you'll compress deep and fast because you are now acting as the pump for the body, and to get blood to the brain and to the organs, and to hopefully restart the heart. Then during that time, somebody's going to be drawing up what's called epinephrine. Epinephrine is a vasoactive medication that will increase the heart rate or to help restart the heart. And then during that time, there'll be other people doing things and trying to figure out why this happened and how to reverse it, or if it is reversible. So the biggest thing here is to know your protocol, which is determined by ACLS, so acute coronary life support, and that is going to be imperative to you remembering how to manage and handle these drastic situations, because knowing what to do can be the means of somebody's life and somebody's life being lost. So just remember all of that stuff. Well, now your patient's gone into cardiac arrest. The important thing here is to remember your teaching and your lessons from PALS if you're in the pediatric population, or ACLS in the adult population. This is going to be the determinant for life or death for a patient. During this time, you're going to have somebody doing compressions to help facilitate cardiovascular support. So that's going to be pumping blood through their body. Someone's going to be managing the airway if needed, so they'll be backing the patient with the ambu bag, as we talked about earlier, or they're going to need to intubate this patient if it comes to that. Another thing that's vital during cardiac arrest is epinephrine. Epinephrine is a vasoactive medication that will help to restart the heart, increase heart rate, and try to increase blood pressure if heart rate and blood does resume flowing through the body. Now, last thing I want you to take away is that in these situations, chaos does not have good outcomes. It is about being aware of the situation and knowing that there are steps that need to be taken, and that there's people in that room who are going to help facilitate that. So it's important to have a team leader. It's important to know your role, and it's important to understand the outcome that you want. And the outcome is always to help that patient with the best odds of getting better. So just remember that.